Thanks. Good morning. Great summary, Arshad, of a very real unmet need in the space of wet AMD management. So the next 10 to 15 minutes, I'm going to go over the development program of Sozinibercept. So this slide nicely summarizes all of the trials, both past and present, for Sozinibercept. On the right, in the dark and light blue, are post and shore summaries that Dr. Sheff will go over after my presentation in detail. But to understand these, it's very important to understand where this molecule has come from. There's 3 trials that have been completed, all summarized briefly on the left in the gray bars. A phase 1/2A trial involving 51 patients with both treatment-naive or previously treated wet AMD. A phase 1B/2A trial involving 153 patients with DME. And then the trial that we'll focus on the top left is the phase 2B treatment-naive wet AMD trial involving 366 patients, a very large, well-designed phase 2B trial. And that really formed the foundation upon which Coast and Shore were designed, and they were optimized for success based on the data that we will go through from the phase 2B trial. Next slide, please. So as you're aware, the design of the phase 2B trial was to enroll treatment-naive wet AMD patients. Enrollment criteria were very standard for wet AMD trials, with one exception, and that was that patients were required to have vision loss due to wet AMD, with best-corrected visual acuity of between 25 and 60 letters enrollment. Otherwise, all angiographic subtypes were enrolled, and exclusion criteria were again very consistent across wet AMD trials that have been recent. So the patients, 366, were randomized equally into one of 3 arms, and all 3 of the arms received monthly 0.5 milligram ranibizumab through the primary endpoint, which was at week 24. In addition to that, each of the arms received a second procedure on the same day as the ranibizumab injection. In the gray bars, patients received a sham injection, whereas in light blue, they received 0.5, and in dark blue, they received 2 milligram OPT-302. Again, OPT-302 was given monthly at the same time as ranibizumab through the primary endpoint at week 24. You can see retention here was excellent in this trial, with 92% or greater of all patients completing the 24-week endpoint. Next slide, please. So the primary endpoint here was mean change from baseline and best-corrected visual acuity at week 24. Key secondary endpoints included patients gaining 15 letters, and then anatomic endpoints, including CST and intraretinal and subretinal fluid. We'll go through some of these, but as you're aware, this top-line data has also been published approximately 1 year ago in the Journal of Ophthalmology. So on the right are a few important call-outs. So at baseline, one of the stratification factors was the angiographic subtype of the lesion, and we'll go into that in a little bit of detail in a subsequent slide. In addition, there was always a thought that we wanted to look specifically at important subgroups of wet AMD patients, and therefore we wanted to look at RAP patients, retinal angiomatous proliferation patients, as well as PCV, or polypoidal choroidal vasculopathy patients, and we'll focus on the PCV patients in a few slides. Next slide, please. So baseline characteristics and trial demographics are summarized here. Importantly, there was balance across each of the 3 arms. And again, patients were very consistent with what you would expect for a treatment-naive wet AMD population. On average, patients were mid to late 70s, 60% were female, the majority were self-identified as Caucasian. Baseline visual acuity was about 50 letters. And then the lesion types are listed here. The minority, as you would expect for a wet AMD population, was predominantly classic at about 12%. And then the majority of patients had either minimally classic or occult lesions, and PCV was detected in about 15 to 20%, and RAP lesions in a lower percent at about 12 to 19%. Importantly, these patients on average had very meaningful disease activity, with mean central subfield thickness of over 400 microns in each arm, and almost 90% of each arm having subretinal fluid, and about 60% having intraretinal fluid at baseline. Go forward. So here's the primary endpoint data. As you know, the primary endpoint was achieved in this phase 2B trial. You can see that Sozinibercept here, 2 milligram combination therapy, demonstrated superiority in the visual acuity gaining 3.4 mean letters more at 14.2 mean letters compared to 10.8 mean letters in the monotherapy ranibizumab monthly control arm. You can go forward. So let's take just a minute here and specifically talk about CNV lesion types. So in particular, CNV associated with wet AMD can be morphologically variable and can be classified using a number of different methods, but using fluorescein angiography, they can be classified as occult, predominantly classic, or minimally classic lesions. And each of these of interest may occur with or without the presence of a RAP lesion. The distinction between these lesion types can be clinically relevant as they may respond differently to specific interventions. Specifically, while predominantly classic lesions are typically thought of as highly responsive to VEGF-A inhibition, occult lesions may be the least responsive. And importantly, the majority of wet AMD patients, just as we saw in the baseline characteristics here, have occult or minimally classic lesions. Go forward, please. So in that context, when we look at the occult and minimally classic lesions, RAP absent in the phase 2b population, again, representing the majority of these patients and the majority of the wet AMD population at large, we see an even greater superior efficacy benefit with combination therapy, again, with 2 milligram OPT-302 in combination with ranibizumab in the dark blue trajectory at the top, gaining 16.1 mean letters compared to 10.3 mean letters with the ranibizumab monotherapy arm. You can go forward. So it's important, though, to always think about the control arm, right? I think the field has had some challenges in the past because control arms didn't perform exactly as you would expect based on natural history or other clinical trial data sets. So we've taken a close look at the control arm here to make sure that we're in the ballpark of what you would expect. Because, for example, if the control arm did not achieve the visual gain that you would expect, you may be falsely lulled into a sense of security that your drug was adding something when it wasn't. That was not the case in this trial, and that the control arm did perform as expected, if not better than expected. So the two bars on the left are the data that I just showed you on the previous slide. You can see in the dark blue the 16.1 letters gained with combination therapy, 2 milligram OPT-302 plus ranibizumab, and then the 10.3 letters gained is the control arm from the phase 2b trial, again, ranibizumab monotherapy. So the arm on the far right is from a trial that was published in 2006 in the New England Journal of Medicine. You're all familiar with it, called Marina, published by Phil Rosenfeld and colleagues, which demonstrated monthly ranibizumab 0.5 milligram visual outcomes among patients with a very similar phenotype to this phase 2b population, that is with occult and minimally classic lesions. So in that trial, gold standard trial with monthly ranibizumab, we saw a gain of 6.5 mean letters. There was a slight difference in baseline best-corrected visual acuity, and we've shown that at the bottom of the slide here, where this population of patients had 3 additional letters at baseline. Even if you control for that and added, let's say, 3 letters to the 6.5, you can see that the 10.3 mean letters achieved in the control arm in the phase 2b trial is still performing exactly as you would expect, if not better than you would expect, which allows us to be confident in the results of the addition of 2 milligram OPT-302 achieving superior visual gains in this population. You can go forward. So fortunately, in the phase 2b trial, it wasn't just visual superiority that we saw. We saw a consistent signal of anatomic benefit with combination therapy as well. So here we see reduction in CST on the left, again, the blue bar being the combination therapy compared to the gray bar being ranibizumab monotherapy. In the middle, you see a reduction in the proportion of patients with subretinal fluid at week 24. And on the right, you see a reduction in the proportion of patients numerically with intraretinal cysts, again, with combination therapy, again, consistent across all of these anatomic endpoints. You can go forward. We also saw greater CNV and lesion, greater CNV and lesion regression. Again, with the combination therapy on the left is total lesion area. You can see numerically improved with combination therapy compared to ranibizumab monotherapy. And on the right, mean change in CNV lesion area. Again, a very consistent directionality of additional benefit with combination therapy. You can go forward. So the last subgroup of efficacy I want to talk about is the PCV population. I think this is a really important population to focus on. PCV is often looked at as a difficult to treat subtype of wet AMD and can be described as the most prevalent form of wet AMD worldwide, largely because of its high prevalence in Asian populations, where it's present probably in over half of patients with wet AMD. Of interest, it's slightly less common among Caucasians at between 8 and 13%. And importantly, the PCV patients are enrolled in the phase 3 trial. This was not an exclusion criteria. We can move forward. Let's take a close look at safety. I have 3 slides here for you summarizing the safety, both in the phase 2B program and also cumulatively across all of the OPT 302 trials. In this slide, we're looking squarely at the 2B data. You can see the high-dose 2 milligram population on the right with combination therapy, and on the far left, the monotherapy ranibizumab arm. And importantly, combination therapy was well tolerated and comparable to standard of care, where there was no imbalance suggesting a greater safety signal in the combination therapy. A couple lines in particular to call out: serious adverse events were identified in 8.3% of the monotherapy arm compared to 5.6% of the combination arm. And then participants with adverse events leading to study discontinuation, there was just 1 patient in the monotherapy arm and no patient in the 2 milligram combination arm. You can go forward. So this slide now looks cumulatively at all of the safety events across all of the completed Sozinibercept or OPT 302 trials. On the far right are the control arms, where it's anti-VEGF monotherapy. In the middle is the high-dose population that's moving forward in the phase 3 data set. And then on the left is all of the OPT 302 doses, including the 2 milligram population. And what you'll see if you compare the monotherapy population on the right to combination therapy, especially the high dose in the middle, that none of these safety signals are higher in the combination therapy. In fact, they're numerically lower for all of these safety events than they are in the monotherapy population, suggesting the combination therapy has been well tolerated with no evidence of a safety signal. You can go forward. For this next slide, we put in quite intentionally, right? The retinal community in particular has become acutely aware of any possible safety signals in clinical trial programs, and this summarizes all of the IOI events to date. Again, we see very low rates of intraocular inflammation here that appear indistinguishable from the control population. Again, the control population is at the far right here in gray, the high-dose OPT 302 populations in the middle, of which there have been over 1,100 injections now. And then on the far left are all OPT 302 doses, including 2 milligrams, for which there have been over 1,800 injections. And again, you can see balance here with the ranibizumab monotherapy population. And of interest, there have been no cases of vasculitis or ischemic optic neuropathy. You can go forward. Thanks. So in summary, I really think that Sozinibercept stands alone. It is the only drug in development that has demonstrated superiority in combination with anti-VEGF-A therapy for the treatment of wet AMD in a large phase 2B trial involving 366 patients. We saw superior visual acuity gains for the combination compared to really the gold standard of anti-VEGF therapy, which was monthly ranibizumab. You can imagine trial designs that undertreat with a control arm for wet AMD. That's quite different than this trial, which was monthly consistent anti-VEGF dosing in the control arm. And in that context, we saw a clinically meaningful improvement in visual acuity. Importantly, we saw consistent anatomic improvements, very supportive of the primary endpoint, and the safety profile was notably similar to monthly ranibizumab injections, with over 1,800 injections of OPT 302 just through the phase 1 and 2 programs.